Okay, let's maybe take that question with a little delay. While we're talking just a little bit, because the session is quite advanced already, let me present the poster title. That's a little teaser in the background. If we could get, yeah, here it is. So you see there's even more, adding to the subject of this session, and indeed it is a continuation of the session of this morning. So let me maybe get the discussion going by asking you, number one, there were a couple of kind of competing techniques for COPD, for diabetes. So what is your impression? Is it for different kinds of applications, or is there a competition where you see that, we'll see in the future which one, is more applicable? What's your take on this?
I can go first. I would say it's different. I would say that it's for different use cases. I don't know that this is on. There we go. It's for different use cases. And especially since prediabetes can be broken off into a very, very different category. And where I think your device will do better in the prediabetes space, mine might do better in the constant tracking of diabetic blood glucose. Got anything to follow up there?
Yeah, I think exactly. I agree with you. I think they are not exactly competing, but they are in different spaces. Like for my device is more for prediabetes, and continuous monitoring definitely helps when you know that you are diabetic, and even eating a little bit more than every day spikes your blood sugar to a dangerous level. So in that time, continuous monitoring is very, very helpful.
Getting this started will take quite a while if you cannot do it here.
Well, I think I can go next.
Yes.
I think first of all, competing is a good thing, right? And then for our work, ear spiral and Sajol's, right? So, her pulmonary listener, right? We tackle the same problem, but from the different angles. So for her work, I think you are more like focused on the passive side of the problem, right? They can passively sense the COPD progression or severity during normal activities. But for our work, ear spiral, we target at, we require user efforts. So I think we just target at the same problem, but we try to tackle it from different perspectives. So.
Okay, fair enough. Yes, there's a question from the audience. SVs, I guess you have another mic.
Yeah, all awesome innovations here and really cool research. I'm curious if anyone has perspective, like, there's a tough challenge already in validating on a small sample set and kind of producing research that's kind of pushing the field forward. I'm curious if anyone's thought a little bit about in their project, like what it would look like to actually be used in healthcare or in a medical setting, and like what are the potential challenges going forward, kind of branching off the competition side, like maybe there's no competition, but are anyone thinking about those things?
Yeah.
Any of you?
So my device is already being used in clinical studies. We're running a 100-person, not a trial, but a study right now for diabetes on cardiac patients, because we'll see major highs and major lows in the glucose throughout their pre-surgical, surgery, and post-surgical stays. These devices, they break down all the time as you get them going. You want to have a lot of extras in the back and make sure your labeling schemes are good to go, where it's more than just one or two numbers, or your CRCs will get things mixed up. It's a whole production to get these studies run, but finding a good clinician is the best thing you can do.
May I add to that? Oh, okay, yeah, you were waiting. Please go ahead.
Thank you. First, I want to congratulate the author for excellent work. What kind of, I feel like missing is the diagnostic standard. So we see numbers like maybe 10% errors or specificity in the range of 60 to 80%. I think, can you please give us an idea of what is acceptable from a medical diagnostic perspective for maybe for most of your work?
I think specifically for a lot of the work that we're doing is trying to support clinical decision, and we're also in the process of figuring out what is a good label for the clinicians to understand. And when we're targeting something as abstract as the severity level, like are you doing worse or are you doing better, that's something that improves the everyday lifestyle of patients and helps clinicians understand and monitor the patients remotely. But in terms of actually acting on it, that's something that we're figuring out on the way, and we're working actively with clinicians to figure out what's the best or what's a good metric to achieve that decision for them as well.
Yeah, sort of to follow up on the last two questions. I think like also a lot of these things are really highly specific to like the signal you're looking at. For example, like I've talked to people who are working on stuff that involves like blood pressure, and sort of the learnings that they have gained from talking to clinicians was that like if the system doesn't work perfectly, then it's not better than my intuition, and so I'm not going to ever use it. But then with fever, I was actually really surprised to go to the ER and talk to clinicians, and they were like, these thermometers that we use that are like $350 don't even work that well. And so like just having something that gets us a ballpark range is actually way more useful as long as it gets in the hands of people. So yeah, it just sort of depends on which signal and sort of like, you know, how precise those measurements actually are.
I can add to that for blood glucose. So blood glucose devices are actually monitored by FDA. So there are FDA guidelines telling how much error is acceptable. So that way, that's like another way to know the device is within good performance on that.
Well, I have a follow-up comment. So for the diagnosis of COPD, there actually are guidelines in terms of the accuracy limits of the spirometer. So for the lung function indices, the maximum allowed percentage error of these indicators are within 5%. So our work is slightly above that limit. We have achieved like somewhere around 7% of the error rate, and we also present our result to the doctors, and they said certainly you cannot use this device in the clinical setting, but you can use your device in a home setting because different scenarios require different, you know, level of accuracy. So.
Okay, I think this is a very important subject. Maybe your question, and then after that, I'd like to, acknowledge the effort that was made to bring in our last author, for your question. But please go ahead.
Okay. Thank you for your presentation. Very nice works. And you introduced lots of works. I can see at the beginning you tell us the gold standard because that's like a clinical level, and you use like cheaper, less intrusive, wearable computing or other computing devices. Definitely there are bias. We expect to get more error, more error. But it's more like a comment. There are different type of errors. Like in clinical diagnosis, false negative is not acceptable, but false positive, probably it's a bit annoying, but in home use, maybe you can accept that. If that can be taken into account, different error types, that would be great. Yeah, do you have any comments for that?
I mean, I also have this feeling that the field of this very low profile, non-obtrusive, early warning kinds of things are not really well understood yet.